Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast. My name is Terry Fletcher. I hope everyone had a good 4th of July and you got some time on this long holiday weekend to spend some time with family, get outside, relax, decompress, and you're ready to get back to work today. I also hope you saw some really cool fireworks. That's one thing that I am obsessed with. If you've looked anywhere on my Instagram or on my social media pages, I am about sunsets, sunrises, and fireworks. So hopefully you got some good ones. You were also safe if you were able to be in a state or an area that they were legal. And everyone is ready just to focus now on the rest of the month. We're at the fiscal year. We've got ICD-10 changes coming up as of September 1st. We've got the coding changes for 2020 coming up. And soon enough, we will be training for next year. So we want to focus on what we're doing right now in 2019, clean things up a bit. And also, I wanted to answer some questions today with regard to a topic that I am constantly getting a question on, and that is critical care. So critical care tends to be a little bit confusing, mainly because I think it's ill-defined in CPT. There's some good information there. Medicare also puts something out in several different areas of their Medicare provider manual, but there's also some things that are kind of gray when it comes to the interpretation of it. So I wanted to give you some examples, some key elements of critical care, and then also look at the coding of it. So today that's really, we're definitely a Codecast today. We're going to focus on that coding part of that. So the code 99291, this is used for critical care, evaluation and management of the critically ill or critically injured patient. And the 99291 code reflects the first 30 to 74 minutes. So it's only to be reported once per day per physician or group member of the same specialty within the same group. And I'll explain that in a minute. That's actually an exception when it comes to this code that actually is in the E&M section, the evaluation and management section. There's also a code 99292. Now, this is an add-on code for critical care, evaluation and management patient, and it's each additional 30 minutes above and beyond the 30 to 74 minutes. So you have to hit the 74-minute threshold before you can add on an additional 30 minutes. And then it's to be listed separately in addition to the code for the primary service. But the 99292, even though it is an add-on code, it has an exception category where it's one of the only codes. Let me rephrase. It is the only code that's actually allowed to be billed on its own on a separate claim form without a base code, and I'll explain it actually in a minute. And then multiple units of the 99292 can be reported per day per physician group. So despite the increased resources and references and all the training and all the definitions of critical care billing and critical care reporting, so many issues still persist in this. The Medicare data that I've looked at and analyzed, it continues to identify 99291 as a high risk for claim payment errors, which perpetuates prepayment claim edits for outlying utilization physicians and location discrepancies, meaning that settings other than inpatient hospital or outpatient hospital or emergency department. So I've seen this trying to be billed in an office, and that's incorrect. So here's what you need to look at if you are coding for these services as far as your documentation element. So if you keep this in mind, as you are documenting these services, then you will be above reproach and be audit-proof. And that's really my job for you here, is I want to make sure that if somebody asks for your records, or if you get put under review, either with a RAC audit or prepayment review, then you can say, here, I'm an open book, here's my documentation. So first of all, CPT and Medicare, they define critical illness or injury as a condition that acutely impairs one or more vital organ systems. There has to be a high probability of imminent or life-threatening deterioration in the patient's condition. So possibly central nervous system failure, circulatory failure, shock, renal failure, hepatic failure, or even respiratory distress or failure. Hospitalists also provide care, but they have to understand that if they're providing care to the critically ill patient, they must perform highly complex decisions and interventions of high intensity that are required to prevent the patient's inevitable decline. So sometimes I'll see that the patient, they even use the word stable, improving, even though they may be listed as critical, and that may not meet the definition or the criteria to bill critical care. Medicare further elaborates in their rules, and they say the patient shall be critically ill or injured at the time of the physician's encounter or visit. And so this again ensures that the hospitalists or any other specialists that are trying to bill those codes show medical necessity of the service and don't continue to report critical care codes on days after the patient has become stable and improved. So here are a couple of scenarios which would be critical care and have no problem billing for it. And these would be, again, the codes 99291 to 99292. So an 80-year-old male patient is admitted to the ICU following an abdominal aortic aneurysm resection. But 2 days after surgery, the patient requires fluids and pressors to maintain adequate perfusion and arterial pressures, and the patient is ventilator dependent. Okay, and there's documented time of 38 minutes. That would be a 99291. Another would be a 67-year-old female patient is 3 days post mitral valve repair. She develops hypotension and hypoxia, requiring respiratory and circulatory support. And there is documentation of 52 minutes spent involved in critical care services. A 70-year-old admitted for right lower lobe pneumococcal pneumonia with a history of COPD becomes hypoxic and hypotensive. 2 days after admission, again, time documented, 38 minutes spent trying to stabilize the patient. And then another one would be, now this one is a little bit controversial only because I see doctors trying to get this all the time and their documentation doesn't support it, but let me just explain. Let's say a 68-year-old male admitted for an acute anterior wall myocardial infarction, so a heart attack, continues to have symptomatic ventricular tachycardia as well. That is marginally responsive to antiarrhythmic therapy, and 35 minutes is spent trying to mobilize the patient prior to stent placement. So for those of you that aren't in the cardiology specialty, when you're having a heart attack, it means that you have a blood clot or a blockage in your artery. And so blood can't get past it to flow. And all of a sudden, that's why you would grab your chest, because that occlusion is stopping that blood flow. And now blood and oxygen and nothing is getting to your heart because that pumps that blood. Antiarrhythmic therapy, because now the patient's developed ventricular tachycardia, that's the heart's computer. So at the time that your heart isn't allowed to breathe, basically, it's also trying to reboot itself. So think about that. Yeah, that's a patient who's in a critical state. And so you're trying to fix the artery or figure out how to get them to a stent to fix the artery, to place a stent to open up that vessel, but the computer of the heart won't work. And so that would be a clear case of critical care. Now, here's where Medicare put in some examples of patients who may not satisfy Medicare medical necessity criteria. And remember, this is all about money for them. So medical necessity is tied to reimbursement. And so if you don't meet the critical care criteria, or patients who do not have a critical care illness or injury, they're not eligible for critical care payment according to Medicare. But they want you to report it using other hospital care codes. So you could use a subsequent hospital care code 99233 to 99231, or an initial hospital care code if it's the first time the patient was seeing your physician under that admission, or if they were a consult physician, because Medicare doesn't recognize consults. So that would be the 99221 to 99223. So here are some examples of when Medicare says it may not be, or they may not satisfy Medicare medical necessity. And Medicare always uses that word, they may not. They never give you a final saying it does not. It says it may not, meaning it's up to you to prove it. So patients admitted to a critical care unit because there's no other hospital beds available. I can't tell you how many times I teach on this, where I get doctors saying ICU visit, CICU visit. There's no such thing. It doesn't matter about where they are, it's how they are. Patients admitted to a critical care unit for close nursing observation and or frequent monitoring of vital signs. Maybe they were there for an overdose or drug toxicity. Now, when they first came in, absolutely critical if you hit the 30 minutes. But now that they're being monitored under the nursing observation, they're considered no longer critical. Patients admitted to a critical care unit because hospital rules require certain treatments, such as insulin infusions, to be administered in the critical care unit. A lot of patients that are getting insulin, a lot of patients that are getting radiation therapy or anything like that, it can potentially cause a heart attack, so they have to be monitored. And then patients receiving only care of chronic illness in absence of care for a critical illness, so maybe daily management of ventilator patient, a vent managed patient, or that maybe they're there for their end-stage renal disease and they're getting management of that dialysis. That's considered palliative, meaning that the patient isn't right now unstable. They're otherwise stable for that encounter. Even though the physician may think they're critical, it's not considered critical care in the spirit of what that code is. And also you run into issues with concurrent care. So critically ill patients often require the care of hospitalists and other specialists throughout the course of the treatment. So payers are starting to get very sensitive to the multiple hours billed by multiple providers under a single patient on a given day, because claim logic provides an automated response to only allow reimbursement for 99291 once per day when reported by physicians of the same group and same specialty. So physicians of different specialties, you can report your own codes and possibly critical care if you meet the definition of critical care. But let's say you're a dermatologist and you've got a patient in ICU that was billed a critical care code, and the dermatologist evaluates and treats a rash on an ICU patient who's on vent management and they're on nitroglycerin infusion and they're being managed by, let's say, an intensivist. So the dermatologist should not report a service for critical care at that point. They're going to code a rounding visit. And same for hospitalists. If an intensivist is taking care of a critical condition and there's nothing more for the hospitalist to add to the plan of care for that critical condition where the patient will deteriorate if they don't add it, then that's not a critical care service. And then when different specialists are reporting critical care on the same day, it's imperative for the documentation to demonstrate that care is not duplicative of any other provider's care. So they need to identify their management of different conditions or revise element in the treatment plan, because that critical care can't overlap the same time period of any other physician reporting critical care services. It has to be separate. So, and then remember, critical care, when you calculate the time is spent bedside or on the floor unit. So where the physician is immediately available and they're immediately available to the patient and not seeing any other patients. And also the CPT book has a complete list of things that are included, certain labs, certain pulse oximetry, certain chest x-rays. There are things you're going to do under critical care that are not going to be included in that time, or should say are included in that time and then are not going to be, that you can also bill separately. But those things are not, and CPT under the code 99291 has the list of those. A couple of things to keep in mind as you're looking at time elements, and I think this will help you again in your documentation. So these are the things that I have found when I'm seeing audits and what they're questioning. So instead of physician time associated with performance and our interpretation of certain services, the time is towards the cumulative critical care time of the day. Okay, so services or procedures that are considered separately billed, like central line placement or CPR, they can't contribute to critical care time. And then when separately billable procedures are performed by the same provider or the same specialty group on the same day as critical care, physicians really need to document or make a notation in the medical record indicating the non-overlapping service times. So central line insertion, not including critical care time, and then performed and give a time. And this will help you really with reimbursement, because remember, whenever I talk about collections and appeals on the Codecast and also in my webinars, I love a collection and appeal, because I want to be able to say, look at my report, look at my documentation, and I'm going to prove that we are above reproach and we should be getting paid for what we're doing. And then activities on the floor or unit that do not directly contribute to patient care or management. So let's say you're doing teaching rounds or you're reviewing literature on that patient. that can't be counted towards critical care. And also time that is indirect care provided outside of the patient's unit or floor. So let's say your physician is reviewing some test results or data from their office, or calling the family from their office. They left the hospital where the patient is. That's not critical care. Even though it's time towards that patient, it's just free. And then family discussions can be counted towards critical care time, but must take place at the bedside or on the patient's floor or unit. The patient also has to participate in the discussion unless medically unable or clinically incompetent to participate. And if they're not able to participate, I want to see a note in the chart that has to delineate the patient's inability to participate, and then also the reason. You have to give a reason on why they can't participate. So credited time can only involve obtaining a medical history and or discussing treatment options or limitations of treatment options. And the conversation must bear directly on patient management. So if you're using any kind of time for discussing treatment options with anyone else, then the physician has to make sure that's documented. And then do not count time associated with providing periodic condition updates to the family, maybe answering questions about the patient's condition that are not related to decision making, or, and this one happens a lot, if it's related to counseling the family during their grief process, that cannot be counted. The conversation has to involve something with regard to decision making. What are we going to end up doing with this patient? Physicians should keep track of their critical care time throughout the day, since critical care time is cumulative, and each entry should include the total time that the critical care services was provided, so 45 minutes total time. Now, some payers still impose the notation of start and stop times per encounter, Blue Cross Blue Shield, but Medicare wants to see total time. Same specialty physician, so 2 hospitalists from the same group practice, they may require separate claims. Now here I told you I was going to refer to this in a little bit. This is where you can code the add-on code separately. So the initial critical care code 99291, that must be met by a single physician. And then medically necessary critical care time beyond the first hour, 99292, add-on code, that can be met individually by the same physician or collectively with other physicians from the same group. The physician performing the additional time beyond the first hour reports the appropriate units of 99292, each additional 30 minutes under the corresponding NPI, so whoever is performing it. And it's the only add-on code in CPT that is allowed to be billed alone without a base code first. They actually started allowing that in 2014. Also, Medicare has issued instructions for contractors to recognize this atypical reporting method. So I've done it several times, and I've only had to appeal it once, and I had to actually educate the payer, and it was a Florida payer, First Coast Contractors, and basically they were just like, we didn't even know that existed in the Medicare record. And so sometimes you're educating a payer. And non-Medicare payers may not recognize that, though. So make sure you know what that payer, if it's a commercial plan, usually they want to have a base code first. So hopefully that gave you enough information that now you're comfortable with critical care coding, or if you're auditing it, you know what to look for, or if you're educating your physicians because they say we're going to start capturing critical care, you can give them some information or even have them listen to the Codecast on what has to be documented and what's necessary to basically stand above reproach. And if you get audited, be comfortable that you would pass. So you just want to make sure that you are documenting everything and really understanding how the process works. So our coding question today has to do with ER visits. So thank you to Pam in Florida. So the question says, if a patient is seen by the ER doctor and both the specialty physician, say our general surgeon, should we also be billing an ER visit with place of service 23 ER? And if so, what if we have the same diagnosis? Because I can see denials happening. So I kind of paraphrase the question. So you have actually a choice as a specialty physician when you see a patient in the ER. The ER physician does not. So if a patient reports to the ER, the emergency department physician basically has to use place of service 23, and they have to use a code from the 99281 to 99285 series in the ER services. But if there's a scenario where your specialty physician gets called in, you actually have a choice, and it's nice to have a choice because it actually works in a positive. So let's give you a scenario. Let's say the patient did come in for ER for abdominal pain. The ER doc felt that this could possibly be an acute appendicitis, so called the general surgeon in to consult or see the patient, Medicare patient. General surgeon determines it's not appendicitis, but it's actually epigastric pain, and he suspects that it could possibly be gallstones. But sends the patient home with an order, pain medications, diet instructions, and with his card saying, call my office next week and we'll evaluate you for your possible gallstones. So the ER doctor would bill an ER visit for abdominal pain, but the general surgeon can bill an outpatient visit for epigastric pain. If you both use abdominal pain, it's whoever gets their bill in first, and trust me, it's usually the ER doctor. And if you both try to bill for ER, again, the patient's going to have very high copay and deductible. And also, one may get kicked out if it's the same diagnosis. But what I recommend, and this is perfectly legal coding-wise because it is still the definition, the general surgeon should be actually coding either an outpatient visit. If it's commercial, it would be consult, but an outpatient visit, so 99201 to 99205 or 99212 to 215, depending on if it's new or established to that physician. And then the place of service would be 22 because it is an outpatient visit, especially if they sent them home. And not only do you make the patient happy because they have a smaller copay, but also then it's considered an office or other outpatient visit. And you don't have to worry about getting kicked out because as far as your claim, because the ER doctor also billed an ER visit and the same diagnosis as you. So strong recommendation. You can do what you like because you do have a choice, but I have seen when several physicians try to bill ER visits at the same time, that becomes an issue. And I just didn't want that to become a problem for you. Our coding question today is brought to you by True Crime Fix Podcast. Follow them on Facebook at True Crime Fix Podcast for every Friday night download. Also find them on iTunes and Spotify. So this week, I'd like to say hello and a shout out to my loyal listeners who've contacted me. And I shout you out if you contact me. If you're emailing me or sending me a really sweet message through my Instagram account or through my Facebook account, I have on the Terry Fletcher Consulting. I'm on Twitter at TerryCoder1. So, shout me out, or on LinkedIn. I get a lot of messages there. Then I'll definitely shout you on the podcast. So Shar in Chicago and Donna M in New Hampshire, Tony E in Orlando, Florida, Sydney in Kentucky, Rachel in Louisiana, Greg in Oregon. I really appreciate the great messages you sent. A couple of you have asked for some proposals on services. So, that's what we're trying to do with the Codecast as well. This is kind of like my audio business card. So if you need us to do an audit or do some training or personalized webinar, anything like that, that's what we're here for. But one of the things that some of my listeners, and I appreciate, sent me some great messages. I also am going to lead into my personal tidbit. So for those of you that have been watching the news, I really appreciate those who checked in on me either through a text, an email, or a social media contact to see if I was okay, because I live in Southern California and we've had several earthquakes in the last couple of days. Oh, shoot, I'm having one right now. Hold on. Oh my gosh. Okay. I'm actually not going to edit this out because my office is swaying right now. Okay, it stopped. Oh my goodness. Okay. All right. That was a small one, but that was kind of freaky. Okay. So recent earthquakes. So on the 4th of July, we had a 6.1 and a 6.4. I should say we had a 6.124. Nobody agrees. Every outlet says something different. And it was located in Ridgecrest, California. That's about 200 miles away from me, but I felt it. I was actually standing at my counter on the 4th of July, basically slicing up ribs to put in my crock pot. And all of a sudden my house started swaying and my wine glasses started clanging and my cat runs under the chair. And I look outside, I'm like, oh, good. This is going to be my life. I'm going to be found somewhere in Rebel with barbecue rub all over my hands in my kitchen. Great. And then on on Friday after 4th of July, we had a 7.1 in the same place. So now they're saying that the 6.1 or 4 was actually a pre-quake to the 7.1 the Friday after. And that was very scary. My daughter and I were sitting in the living room on our couch, and we were watching a baseball game that went into extra innings. And all of a sudden, and she's 24 and she hasn't really experienced earthquakes. She said she's a couple times thought she felt one, but she's never really experienced a real one. She's either been asleep or just hasn't realized it. And we're sitting there minding our own business. And she's like, Mama, the house is swaying. What do we do? What do we do? And the glasses started rattling and the cat runs somewhere. And it was about a minute. I'm like, just hold on. Just sit there for a second. And what you do is you wait for a minute. And then if it goes beyond a minute, which they usually don't, they usually just go for a few seconds. But after a minute, you're like, okay, this isn't going to stop. You go stand in the door frames of your bedrooms, because if your house starts to fall around you, the frames are going to stand up. I'm sure you've seen destruction and certain construction sites, you'll see door frames still standing. And so that's where you're supposed to stand. And so it was very scary, because then we had 2 aftershocks right away. We stood there for a few minutes, because then the house has to kind of stop swaying. And then all of a sudden we had another one that felt like about a 4.5 and another one that felt like about a 5. And I'm like, oh, please stop. So it's very scary. And I live on a golf course. So if we had to run outside, we'd be running out. I live on the first tee to open space. And so I'm not too worried about that. Couple of trees out there, but we run fast. But it was, again, that one was the same place about 200 miles away from me. And it felt like it was about 50 miles away. Very scary, but we're fine. So thank you for the shout outs. And that's what California living's like. So not a whole lot you can do about an earthquake. A couple of my friends said they were driving and it felt like somebody jumped in the back of their truck and just started shaking it back and forth, or jumped on their car and started moving it. And some of the traffic lights were kind of swaying back and forth. So I'm glad I wasn't in a car. I was a few years ago when that happened to me, but yeah, that's what we're dealing with in Southern California this week. So keep your eye on the news, but we're good. We're fine. It was far away from us, or at least far enough away where I'm comfortable it didn't hit us. But yeah, I wish all the folks out there that are in the Ridgecrest area that they're safe. And I know they just ordered a state of emergency, so federal funding is coming for them. So hopefully they're okay. So everyone, make it a great day, a great week, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.